You're welcome back. This is Newsfile. It's your most authoritative news analysis platform. I'm your host, Samson Ladi Ayenini. Wherever you are this morning, take very good care of yourself. But keep your dials here on Joy 99.7 FM and our affiliates across the country. And also keep watching us on Multi TV. This is your Joy News channel, because we will assist you with sufficient knowledge to empower you, in addition to your prayers, more importantly, to be practical and intentional about protecting yourself and your loved ones. Now, this is what I have by way of my take. Take a look at it.
Sober up. COVID-19 respects no national borders, no social bounds, no political systems, and no cultural values. It hits us just as hard. It levels the world. Facing the pandemic, it is not what happened matters. It is how we respond. For almost a month, it infected thousands in Wuhan in a day, and every hospital bed was occupied. Now, empty beds and closed wards in the city. How did China make it? It is nothing new, but it's worthy to know. According to an initial WHO report, an infected person appears to spread it to an average of 2.6 people. And after 10 generations of transmission, with each taking 5 or 6 days, that one initial case has spawned 3,500 in matters of days. And that is what the world is seeing. What China did is to break the cycle by human intervention. The scale unprecedented in history. Extreme, draconian, and aggressive. These are the words used to describe China's response. But now, people have come to terms with the new norm, lockdown. Some people say, isn't that a violation of individual rights? Actually, the balance between individual rights and public safety is always an ever-changing equation. After 9/11, all the airports in the world began to impose draconian safety checks on passengers, and people accepted it because we traded a little of our freedom for the greater good of the public. China imposed the largest and most draconian quarantine in history. Factories shut, public transport stopped, and people stayed indoors. By doing that, it flattened the curve. On one hand, China avoided many millions of cases and tens of thousands of deaths. On the other, it stretched out the time and made the hospitals restaffed and less strained. This is exactly what Europe and America should know. But public policy needs both ends to agree, the decision makers and the decision takers. Quarantine is indeed extreme and extremely restrictive. It needs the people in lockdown to be honest and cooperative. I think what the people of Wuhan did was exceptional. They had the courage, tenacity, and resilience to stay housebound for days, weeks, and months. Most view the quarantine as a civic duty, and that is why it worked. Public health methods are universal. They either work or they don't. We are all human beings. Our epidemiology is the same, but we have different economies, demographies, and sociologies. Facing a global pandemic, every nation needs a new contract signed between its politicians, businesses, and the public. Desperate times ask desperate measures. This is a desperate time, and we should not put politics ahead of public health, now more than ever. The new coronavirus has been claimed by ideologues. Donald Trump said it justified tighter border control. Bernie Sanders linked it to free healthcare. While in Singapore, every infection case is followed and dealt with. Bit by bit, every country is testing its methods through trial and error. Some paid a high price, and some set a high bar. We should all move ahead with humility. There is no decision without trade-offs, and most of all, there's nothing without skin in the game. And now, the whole world has learned or is learning to play.
And that's by way of my take. The corona chaos. Take care. And in Ghana, I hope we don't play any further with it. The NIA, National Identification Authority, is an entity in the office of the president. The president cannot issue directives and measures to protect us, and yet the NIA will act so lawlessly and disregard human life and health. It shouldn't take individuals to sue the NIA and file for contempt against it before it tells us this morning that it has cancelled the clear and present danger that it offered the people of the Eastern region to potentially spread COVID-19. That reckless act must never continue. My guests are in the studio, and before I started, I did announce to you that the world number recorded was 277,100 and something. This minute, it has gone up by 277,203. In Ghana, the number is not what you already know. It has gone up. And as we know, community infections are beginning. That is what the health minister says. We should get ready for the worst. My guest in the studio will help us to navigate Corona and get ourselves ready, well informed with the facts, and deal with our fears and how we navigate the circumstances in the stress, staying calm even in the emergency. In the studio, Dr. Patrick Abuaji is Director General of the Ghana Health Service, and also Dr. Titus Bayo. He was here last week. He's Deputy General Secretary and member of the Infectious Diseases Committee of the Ghana Medical Association. Gentlemen, good morning and welcome to Newsfile.
Good morning.
Right.
Thank you.
So this morning we are big on your situation also. Wherever you are, how you assess how Ghana is doing, let us have your views. How have you been coping with the measures? What have you been doing to prevent coronavirus? Let us know your experiences and how you are managing in the current circumstances. So, to start with, Dr. Patrick Abuaji, Director General of the Ghana Health Service, where do we stand now? Where do we stand now? We got the latest announcement that we have 16, but we know that now we have more than 16, except that we have to go through certain processes and make that official.
Yeah, thank you very much. Yes, currently the number has increased from 16 to 19. And sometimes you don't get the results as quickly as one would expect, because for the service, positive is just one information, but for our response, we need a lot more information. The client will have to be informed about the status, and that takes through going through the facility that refer them and inform them, because that doctor will know how the person is going to take it, so they will know how to break the news to them. And then we also need to establish contacts immediately. The treatment team, for which Dr. Bayo is one of them, is activated immediately. And when all those things are done, then we can now update the data and to see whether is there an imported case, is it a local case, and that a lot of information that will have to be gathered, especially for the contact tracing team to start.
Okay.
And so it may seem that's probably not coming out as quickly as possible. We need to go through those processes to protect. Even if those who are negative are supposed to know their status. So before, because we don't want a situation where now there are two positives and you have 20 people testing for that, then they wonder, is it me? Is it the other one? So that is why there's a delay. But currently the number has moved to 19.
Right.
There are about 1 or 2 that we are still a significant number are all imported cases. There are 1 or 2 we are still following up, especially the one that we're not too sure whether we cannot identify any contact. But I will follow with the contact tracing to see whether it is a clear case of community spread, which will not be surprising to us.
And more importantly, as you say, we only know of these 3 additions as being tested positive, but we don't know whether they are community infections, and all of this is important, and we need to know all of that.
Yes.
How does that, what does that do to you as those at the forefront of helping the country manage this situation?
Yes, when you have a case that is not imported, I mean, even if it's imported, it is because they are the imported cases that are going to go to the next contract and move to the next contract. But when you start with community spread, then you are looking at the exponential graph that you showed. Right. It means that the risk, especially the way things are going on, that we get worried that this may get out of hand if we don't abide by some of the key interventions for us. And that also means that we need to abide strictly by some of these interventions that have been coming primarily to reduce contact and grouping so that we can really cut the transmission from one person to another. So that is where we get worried about.
Thank you. Dr. Bayo, so this latest addition from the point of 16 to 19, is this something that you, the clinicians, expected, or you actually expected far more?
Well, usually we plan for the worst and then hope for the best. I should say that to the extent that most of our infections are still imported, then the trajectory is expected. But as soon as we are beginning to see more of community spread, then we expect more. So most of us expect that the numbers may actually be more than the 19 we are reporting. And some factors may be that there are people who may still not be showing symptoms yet that we haven't tested. And for very good reason, we are making very judicious use of the testing system. And therefore, not all contacts are tested, and not all people who have returned are tested. So it is possible that the number currently may be far more, but this is what we have. And it is not out of expectation, let me put it that way.
Right.
Yeah.
It's how dangerous is it to think about the fact that in the incubation period, people can infect, and to also think about the fact that within that period, because you do not know that you have, some people actually have not shown symptoms, but have tested positive.
It is extremely dangerous, and I think it explains why the disease has been difficult to control, except with very extreme measures in some countries. And it is dangerous to the extent that, like you mentioned, people may not show any symptom and may actually be spreading. Now, the danger then comes in twofold: to the community and even to the health workers, because some of these people may report to hospital with other conditions and may end up infecting health workers because they have not shown any sign. They may end up infecting people who are very vulnerable because their immune system is low at the health facilities. And therefore, that's a danger there. In the community, because these people do not know their own status, the level of social distancing may not be respected as we are advocating for. And that fuels the spread. And it's because of these that in some countries, very extreme measures have been taken, like the lockdown or mass testing, all of which in a particular jurisdiction, you have to weigh your options very carefully before you jump to that level. Of course, the mass testing would be a very good one. Yield may be low if we do not select the people well, but it comes at a cost. And if you are having global shortages of testing kits, they have to take critical decisions as to how you go around this testing so that you don't end up missing the people you really want to test. But those are the extreme measures that can really tell us the actual yield, because it is dangerous when people are shedding without knowing their status.
Right. So what informed your statement as the Ghana Medical Association asking the NIA to stop its processes, even when you say most of what we have experienced so far is imported? that lessens the danger.
Yeah. So in fact, let me begin by expressing my disappointment with how the NIA has handled this. I'm very, 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 very disappointed, and we in the medical fraternity are very disappointed, to say the least, that it has to take a court action for them to reason along. So the question we're asking ourselves is, should court come out today and then they listen to the actual case and then say that, okay, the people who brought the suit do not have merits? Is the NIA going to continue? Because we gave medical reasons why, public health and safety reasons why the NIA should stop. Simply, we cannot understand why the NIA took the path it took. Be that as it may, we are grateful that by the intervention of the individuals who sued, now they have stopped. Now, what we have been crusading and talking about...
The point is that they have not stopped because you issued a statement.
Yes.
Because when you issued a statement, they called your bluff.
Yes.
Then the SHRAJ,
the
independent institutional body in this country, also issued a statement on the public health and the right to life that they were endangering people about. What you heard was people saying, let's check when the SHRAJ boss was appointed and which political party it belongs. As if Corona will look at your party, color. Then, what they've actually issued, the statement, they say that the mass registration exercise currently underway in the Eastern region has been suspended effective Saturday 21, 2020, pending the final determination of the application for interlocutory injunction. So what they are saying is that because of the suit, otherwise they would not have stopped. They won't listen to you.
It's exactly my reason why I express my disappointment with their action and their line of thoughts. You know, we didn't come out of this with this statement out of vacuum. As a nation, we really all appreciate, and for us in health, we know the dangers that this condition poses. We know how prepared our health systems are. We don't have to wait to get to that point.
You mean you know how unprepared or how prepared the health systems are?
How prepared we are to handle at various levels.
Okay.
You understand? I mean, for the level at which we are, the health system is doing its best. We know as medical practitioners that if we get to the next level, where we have a mass community outbreak, where we need to test 10,000, 1 million people, our system will be stretched. When we need to isolate over 1,000 people, we cannot cope with it. And so we were issuing that statement as a precautionary measure. So we would not understand why a government agency working under the office of the president would defy it, will not take our advice. SHRAJ will come out, they will not respect it, and go on until the courts come in. And people were asking, is there already evidence of community spread? For heaven's sake, should we wait to see that we have it? Okay, the day after we issue that statement.
Is it not important that they showed you pictures later of the measures that they are taking? So they are saying they are practicing social distancing, and their officers will have sanitizers, they had gloves, and they had face masks.
I rather we don't go that line. The truth is, we know that is not what was on the ground. We had doctors in the regions. We have a divisional chairperson in that region. We have doctors in all the areas where they were registering. And we contacted people. We made our statement based on very informed decisions. What happens is people mass up, people are assigned numbers, those finally selected for the registration go in, and they are spaced out. So at that pre-trial stage, what happened?
Okay.
That's even in hospitals, we are doing triaging. We are screening people who are coming. We are trying to decongest hospitals. Okay. We are telling people who need to come to hospital that if it is not urgent, don't come. How much more a registration exercise?
I see.
What is the urgency there? You know, so I really wish we didn't go that way. But I mean, I just hope that in the midst of all this, some reasoning will come to play, and that at some point they themselves will realize that aside the court suit, the caution that health workers are putting out there is worth its merit.
Okay, right. Now, Dr. Bayo just mentioned that when it gets to a certain point, we may be stretched. Yeah. So our prayer is that we don't get there. Yeah. Question is, what are we doing to avoid getting to a point where we'll be stretched? Because I'm filtering the news in America, in the United Kingdom, Italy, I don't want that as an example. Yeah. And I can see how all the best medical systems have been stretched. PPEs are not enough. Hospitals are improvising. We talk about ventilators, and we find out that where we may need to import them from, they don't have enough to give us.
Yeah. Thank you very much. I think that is the point that we started and trying to avoid, and that's why we're looking at early detection and containment. We were not going to kid ourselves in thinking that we can prevent the case from coming in here, because it's global, and with the travel situation, it was quite easy that it's going to come here. But the issue is to look at that. So what our approach has always been limitation of importation. And that's why we started with education, declaration forms at the port, health, to also identify risks, etc. But of course, that was not going to be enough. And so additional measure that the president announced was practically to reduce importation, so that certain categories of people cannot come here, because you can also say a Ghanaian cannot come back to his country, and those who are resident cannot come to your country. We needed to put certain measures like quarantine and self-quarantine to limited. So that's the key thing. The second one is containment of importation. So that even when you have come in, then are we going to quarantine you? How are we going to follow you up and going to make sure that you do not get to mix with people? But the most important aspect is limiting community spread. And that is where we are talking about closure of schools, closure of universities, because you see, you don't wait until you are forced to close. So before it starts, close. Because the way the virus spread has a very high, what we call attack rate, quite high. And so it's very easy to spread very quickly.
Yeah, the experts say that one carrier can infect as many as 4,000 within weeks.
Yes. Because that one is exponential. So I infect 2, the 2 infect 2, that becomes 4. Then you start expanding, everybody's infected everybody. So it's quite, so we're trying to ensure that we are limiting community spread by talking about social distancing, sanitation improvement, making sure the markets are done in such a way that people are not
Dr. Bayo said we are prepared to whatever extent that our capacity can. Are we really prepared? We are talking about only 2 laboratories doing the testing. Accra, Noguchi, and KCCR in Kumasi.
Yes, but you see, our response has not just been the status quo. In addition, we are working towards expanding access to laboratory tests. Prior to that, we had only Noguchi. KCCR came on board. We expect that within a week or 2, we have at least 2 additional centers that will be doing testing.
You're expecting 2 additional centers? Where?
We're looking at Tamale and Ho. There's a lot of work going on to ensure that they are also able to test.
So that we are likely to have 4 in total?
Yes, and so... And
you're saying you expect this to come on when?
Within a week or 2, it should be able to.
Within a week or 2?
Yes. Under the
That's the period it takes for one person to infect as many as 4,000.
Yes, but that is if your containment methods are just loose. And as long as people go, I mean, you say companies should allow people to work from home. If you don't need to go to the bank, don't go. And these are the things that we need to carry the people with us.
Containment method you speak about, the WHO says this point, they started with containment. Now they say test, test, test. Yes. You have only 2 centers. You are seeking to increase that to 4. That is woefully inadequate. And that will come on board in 2 weeks. Within the 2 weeks, if you have 1 carrier, they could infect as many as 4,000.
But let me also tell you that even the capacity at Noguchi is high enough to do over 1,000 tests a day.
Okay.
It's about moving the samples to the place. And like Dr. Bayo said, these are testing policies that you need to ensure that can you afford it? Is this something that you can look at? So those are all the actions that we... But I'm sure we are ready to expand and treat more. The epicenter has basically been more in Accra, and now we have about 3 cases from Ashanti region and Accra. So those are areas where we...
Of course, the 3 new ones, we don't know where they are from. We only know that they are positive. They are also from Accra?
No. They are, okay. And for the last 3 new cases are actually imported cases.
They are also imported? Yes. You have confirmed that?
Oh, yes, but in between, those in the there's still 1 or 2, we're still trying to identify the contact, whether it's a contact of somebody who imported and probably come and gone or something. So those are the things we're looking at. But we need to ensure that everybody played their role. This is what you saw in China. The people came to the table, they were there, they abided, they were not all the rules. But now you see town, everybody is in town, people are not, the groupings are taking place. Those are places that we need to ensure that people become more cautious and apply the social distances. Now the local government is trying to get into the market to ensure that it can bring some sanity, etc. So that still to reduce the possibility of a spread. And that's a very important stage. And I'm happy we have started early enough. And if everybody comes to the table, because if people don't abide by this and don't see the risk and also participate, it becomes very difficult for me, Dr. Bayo, or anybody, or you.
Right. So I was looking at elsewhere where we would always fall on and depend on who are now, overstretched. They are building new facilities or make up temporary places around the hospitals to, accommodate more people by way of quarantine, and so on and so forth. When we talk about the PPEs, all the equipment that you need, what exactly are we talking about? Can you take us to the basics? What are the things we are looking at?
We are looking at things like gloves, masks of different types, depending on who is wearing it and what you're using it for, and identify the surgical mask. We're also looking at the coveralls, aprons, and so depend, and you also have the caps, etc. So there's a whole regalia. I mean, the full regalia is the person who is going to treat an affected person.
Okay, so this is intended to give protection, an assurance of protection to the health workers.
And the people. Because when a health worker closes work, he's just like one of us. And so that's still part of the process. And those are the things that we need to do. We are looking at the pre-triaging where you select people who are likely to be the first.
We understood we had a certain initial quantity and we were looking for extra. We had asked for extra. What are we talking about?
Before the incident occurred, we had reserves from that were not used during the Ebola time. Okay. We quickly brought in 5,000. We brought in 3,000. We had other donations coming in. But the government is ordering a few more. Like you are aware, because of the global crunch, and a lot of the PPEs are produced in China. We have to, but we know that China has started production. And so additional ones will be brought in quickly. There are a couple of companies that but you don't have somebody who has 50,000 PPEs.
So what are we looking at? Because the people where we are going for are the hardest hit, well, they are recovering. So what's the time estimation we're looking at? How long will it take to get the next consignment to us?
Like I said, there are organizations, lucky enough, there are individual Ghanaians and organizations who have actually brought them in. And these are the ones we are mopping up to bring it in whilst we wait for the bigger box. So there's a lot of organizations, and Dr. Bayo knows, who have approached us. We have this number, we have that number. But of course, we are competing in the sub-region. Nigeria is looking for some, Benin is looking for some, Togo is looking for some. So those are the ones we are quickly mopping up whilst the bulk will come in.
So is it automatic? Is it certain that the sort of COVID-19 curve that you have become familiar with, any country that is affected must necessarily do the curve before they come to a recovery? And what will that mean to us? I've been following and watching, for example, Iran. Within how many days, how many have been affected? Well, Italy is not a good example, but in 10 hours, and you have 600 deaths. That's not an example you want to look at.
No. So the best would be to avoid this, to flatten the curve very quickly, let me put it that way. And that is why a lot of our effort should be at the initial stages.
Explain the curve and the process to flatten it.
So the whole curve is that for such an epidemic, it starts, it exponentially goes very high, and then by that time the system gets awake, very drastic measures are taken, and then there's break in the transmission. And once that break in the transmission is achieved by whatever means, then you begin to get the numbers coming down, because the disease runs a natural course. And so most of those infected will either recover, or those who may unfortunately die will die. And then the burden of the disease goes down. So once there's no new infection, we expect a normal drop. Now, for us, how can we prevent that exponential rise? Because that is where our issue is. You know, there are different levels of this battle. And if you look at the clinical disease, it's graded as mild, moderate, critical, severe, and critical. Our greatest worry from the point of clinicians is that we do not think our level of preparation when it comes to severe and critical is up there. Because in the well-established systems, they are struggling at that level. And that is where deaths occur. So we are trying to prevent as many people from getting to that severe and critical stage. So how do we do that? And I think at this level, there are just about two things. First is the test.
Right.
So we identify, because you see, we are trying to carry the population along. How do people get along if they don't know their status? So if I want to make sure that I don't infect other people, I must first know that I'm infected so that I don't infect other people. Then the other means is the public education, that is obeying the social distancing and all, because that is what will also prevent the spread. So that people who are not even certain, if we all obey the rules, then we are able to present. But I think the testing, so if you remember in our release, we asked that all regional hospitals should be given the capacity to test. And we should add the public health reference lab and other labs to be able to test, so that the testing is closer to the people. The other thing is an efficient call system, because I see this from two main perspectives: managing the health workers and managing the population. If you ask me to self-isolate and you give me contact lines and I call those lines and they are not going through, I call and no one is responding, I call and I'm unable to reach anybody, at the least sign or symptom, the first thing, the person will panic and will jump out into the public and will rush into the hospital. If you go to other countries, what they have done is that they have decided that don't come into a hospital, call. Because you see, if you are a suspected case and you even walk into a hospital, touch wood, if you are really a case, by the time you make a folder, go through the system, you would have infected other people. So if you have a very efficient call system, it is something that I still do not understand to date, why we still have the very long numbers. I have made this personally known at various levels that by this time we should have that unique code, which is very efficient, backed by a very sophisticated IT system that almost everybody calls and gets through. But if you are still using these long numbers, you have to give a number that's 10 digits, people have to try and memorize, and even when they call, it's not going through. It makes that community mobilization bit difficult.
All right.
And then the testing. As for the testing, currently, I mean, I'm privy to the difficulties we have as a nation. And so we cannot do mass testing for anybody at all. That, I think we all must agree with the system, because till such a time that we think we have enough testing kits to do that mass testing, then we look at the epidemiology of it.
You're saying that if we had enough testing kits,
yes,
we could have started mass testing now.
If you have enough testing kits and testing centers. Because the mass testing has been shown to be effective.
That's why the WHO says test.
But you have to localize it to your country.
Okay.
How much do I have? What capacity do I have? What is the burden in my country now? And how do I apply it? Because I bet you, if we open up the floodgates and say, anybody who feels like testing, get tested, perhaps in a week, maybe we'll run out of the kits. And then what happens? You get it.
Well, as I follow the news and I hear about the need for ventilators, among other things, what is the role of ventilators in the process to help this situation?
Okay, so the ventilators are in that last stage, the severe to critical phase, which I said we wish that as a country, we doctors, nurses, everybody wish that we don't get there. Where we have a lot of people who are sick, who are in severe or critical stage, who cannot breathe on their own and need to be put on a machine.
And that's what the disease does.
Yes, that's what the disease does.
Gives you the problem to breathe.
The breathe.
Okay.
To breathe. And this happens so far from the epidemiology we are seeing to people who have underlying health conditions, very old people, or people who are severely affected. They get to a point where they are not able to breathe on their own. Now they need a ventilator to breathe for them.
All right.
Now, at that stage, honestly, I don't think our system is well prepared for that yet.
That's the stage where the clinicians or the physicians were told make a decision on their own who to help and who not to help. The information we have is that the whole of this country, we have about only 50 that are functioning. That's woefully inadequate, correct?
I don't have the exact figure, so I will not want to put out a figure, but definitely it's inadequate. I mean, I can tell you that if you go to a major hospital like
we need them in the hundreds.
Exactly. I'm telling you that in the stage of outbreak in Italy, there was a pre-release 601 ventilators there, and they were all in use. And the Italian Medical Association and practitioners had to make critical decisions like what you are saying, a sort of a triaging. Who do we put on? Who do we take off? And that is a decision no doctor wants to make, because essentially it means you are telling someone you are good enough to die, while this person should be given a chance on the ventilator. And to the extent that we don't have enough of them in the country, we will struggle to even get them to purchase when we want to even purchase. It means we should start having our systems in place to prevent us from getting to that level.
Okay.
That's severe to critical. But what we have now should also be efficiently managed. And it's not only the ventilators, because the ventilator is a specialized machine. You need a critical manpower to man those machines. So even if you buy 200 of them and distribute them across the country in a district hospital, and there is no anesthesiologist, the normal health workers there cannot put a patient on this ventilator.
Okay.
And they cannot monitor the patient. They cannot do the settings to make sure the patient is safe on it. That is where the challenge comes in. So I think that our best bet is to try and make sure we don't get to that level.
All right.
That the numbers reaching that level are low. Whilst we are at that, the managers of the system, like Dr. Abuaji and his team, have to look at how do we efficiently distribute the few we have in the system.
Okay, and there's a Ghanaian doctor, Samuel Kojo Amwakuhene. He's an anesthesiologist at Connecticut, and he has an idea and has been demonstrating how you can use one ventilator to take care of multiple people at about 4. But the doc, what are your expectations at recorded cases of 16? We said we had as many as 600 contacts that we're tracing. At 19, what is the expectation?
Well, the expectation that it will be higher. And currently we are, for the first 16, we are doing about 590 something contacts. We've covered, based on some of the cases, we covered contacts about 100%. There are some we are doing about 98%.
Okay.
And they are all, fully covered. The additional ones depends on how long the person is and how cooperative we are able to look at it. We are using actually the SOMA software to actually follow them up and see how we can see how many we have seen. But Dr. Tito just made some few things about the calls. For the past 1 week, we moved to 112, and so that is available through the Ministry of Communications, which we are using. Like I said, these things just comes at you, and so you run after that, and then we look at that. But our people too must be also be helpful. If someone decides, let me test the number and see if it works, then you jam the number. And so if everybody testing to see if the number really works, then the person who really need the number, and that's what was going. We looked at about 150 calls. Number 120 of them, they just asked whether we wanted to check whether the number is working. And so these are all practices that we must stop. But we are doing the contact tracing. As the more comes, it's exponential. On the issue of testing...
Can you explain that to our listeners and viewers? When, at this point, the minister says what should be expected is exponential, rates at infection, what does that mean?
Well, what it means is that because the people are already coming with cases, they have made contacts have made contacts. We are looking at it. But the good news is that of the contacts, we've tested a couple, and so far none of them have turned to be positive for now. And so one expects that with exponential growth, there's likelihood that there's somebody who may have picked it. There's somebody who may have come in without symptoms and also come for testing, and so that person may be under the radar.
Okay.
So those are the expectations that we don't want to take chances on, and that's why we are also brought in this issues of that reduces contact as much as possible to preempt any or reduce the possibility of spread. But the contact tracing, what we are doing as well is that for those who are sitting in the flight, because we have the manifest, we have a pushed text message now who will tell maybe all of you on the same flight in KLM, you get a message so that you can also come around.
You may not be in a position to take these sort of decisions, but would be advising certainly. Yeah. For example, California, elsewhere, have taken a decision. So far, about 3 states in the US, as we know, I think the number may have increased by now, have decided a complete shutdown, stay home policy. At what point should that be within our contemplation, particularly given the speed at which the disease spreads? When we started the show, the global recorded total was 277,000 plus. As we speak, it's now 278,534. The deaths now at 11,554. Of course, there's also the part that I like to talk about, which is the good news, that 92,906 have recovered. In Ghana, we had a story of one of those people yesterday who was tested and now, is doing well and is excited about what is happening. When do we get to the extreme measure of a shutdown?
Well, I mean, if I want to apply public health principles, that will be now. Well, we don't live only in public health systems only. We have other parameters to consider.
You're saying if you were to advise, you say now, shut down.
Yes, looking at just only the public health principles alone, it will be now. That would be the best. But there are other ramifications. And so those are those things that the powers that be will need to calculate and make sure that at the earliest point, such systems are put in place. But for me, even the kind of introductions things that have come in now, if we are disciplined enough to abide by them, it will significantly work. Well, the fact that they say we have closed schools doesn't mean that go and meet in the park and play football because we have time. We need to ensure that we stay home. We ensure that we don't go out. If you don't really have to go out, you don't go out to the mall just roaming to see what's going on. These are the things that all of us.
In fact, if you have to be in a gathering, you must be not more than 25. Unless you are the NIA, you must be not less than 25.
I don't know where that 25 is coming from.
That's the president's.
No, that's for funeral, private burial.
Oh, I see.
So that's for private burials. So I don't know.
Only for burials.
Yes.
Okay. How about weddings?
They're all banned now. All gatherings are banned. I think
really?
The weddings, what the Accra Metropolitan Assembly came out officially was that you are perhaps allowed, just you, the couple, 2 witnesses from your family, 2 witnesses from the other family, 6 people. But the 25 is for private burial. And I think people have interpreted
looking at our social context.
that it's difficult to say people should not bury.
All right.
And I mean, there are ramifications on that,
Yes.
Because mortuaries are getting full. If you say no one should bury, where do we keep them?
Yes.
So just the burial is what is allowed for that one, So I think.
So I mean that will be the thing, but I'm sure other measures will probably kick in to ensure that we have reduced importation, reduce contain importation, we limit the spread, and most importantly, care for the sick. We currently have centers across the region where treatment can take place. We are not going to do grouping into specific centers. We are spreading everywhere so that Kolebu should be able to manage their cases, Rich should be able to manage their cases, and other places, so that we don't really have this. But we are working very hard. We are looking at the resources that we are being privy to now, the essence is not just to fight only, but also prepare for the next outbreak. And that is why issues of ventilators and this are being procured to beef up the system.
Samson, I just want to just
okay, so all of you had said, and particularly you, because of the special position you and role you play, you had said that you're expecting other details before the 3 new ones would be updated on the website. So on the website now, it's been updated. That's the Ghana Health Service.org website. It's been updated. So if you like, once again, to be double sure, it's 19. It's 19. I'm looking to get the details of the new infections and what exactly they represent. I'll look for them and then perhaps we will find out. But you had confirmed earlier that they are all imported too. Yeah. Right. Okay. You are about to make a point.
I was going to say that the health system is working hard. Our public health colleagues are putting in their very best. I think we need to commend that and commend what government is doing. However, there are a few things I think that needs to be improved. And I think we need to look at communication and communication and communication. And the communication in twofold. Communication to the general public, communication that inspires confidence, that lets people know that we are doing our best at this and carry the people along. And more importantly for me, from where I'm coming from, is communication to the health workers. And I think we should have these 2 communication channels very, very well outlined. The people at the front line of this work must know more detailed information than what is given to the public, and that should guide them in decision making and all of that. For instance, I have been privy to the detailed work that is being done as far as contact tracing is concerned. And when I got the details, I got so confident and I was like, this system is working. But how many people know this? And I think that especially for us who are the front line should know, because I, for instance, know yesterday how many people were called on phone, how many people they went to visit. If you take the Legon one, for instance, they went to the halls of residents to meet the people who are supposed to be exposed. This type of information should come up to inspire us confidence in the system that people are working. We know, we've heard in the media that there's some form of insurance policy for frontline health workers. The people directly involved don't know what is in it. So is it life insurance? Is it insurance that covers critical illness? So if a nurse caring for somebody with COVID-19 gets infected, what does the person get? Is it only when he or she passes on that something is going to be given to their family? What some of this information will come out and then will inspire people, I think, to go on.
Dr. Boaji, are you in a position to explain what he's talking about the insurance, what exactly it covers?
We have 2 types of insurance, and we are working with the associations like GMA, GRNA in determining the package. First is the insurance, life insurance, for which we have done for a number and anticipation. We hope we never ever get even 1% of that. And then also the second level is, I would say, injury, mobility, etc. Those are also there. And there are also some little incentives for the frontline people who are looking at some of these things. You need to build consensus with the associations before you put it out there. As to whether they accept, and he knows that it is there.
Let me give you details about the 3 new cases, and then we'll take a quick break. When we return, I'd like particularly Dr. Boaji to try and give us an answer, if he has, about questions that people are asking, because at Kolebu, as we understand, there's a construction that has begun for the purposes of COVID-19. Questions people are asking. We have magnificent, well-equipped facilities that have been built and are not used or underutilized. Why are we not using those facilities rather than seeking to build new ones? Questions Ghanaians are asking. Of course, it's their task, their tax that is used for these purposes. So the 3 new ones, number 1, is a 55-year-old Ghanaian woman, resident of the United Kingdom, returned to Ghana within 2 weeks. Sample confirmed positive in the laboratory. Number 2, 84 34-year-old Ghanaian lady, resident of the United Kingdom, came back to Ghana within the past 2 weeks, developed symptoms, and sample confirmed positive in the laboratory. And the third one is a 27-year-old Chinese male, returned to Ghana in the Ashanti region in the past 2 weeks, developed symptoms, and sample confirmed positive in the laboratory. And the update now says this brings to a total of 19 confirmed cases in Ghana with no deaths. Contact tracing has started in all these cases. Dr. Bayo actually correctly said, as you follow experts across the world who say the numbers reported do not represent the exact numbers. We'll get him to explain what he means by that and what the risk in that is, particularly as we have discovered 3 community infections so far. We'll be right back.